Okay, this is the cardiovascular system chapter on the heart. And what you'll see is in the beginning, I'll go through the slides, but I'm going to be going very fast through probably the first half of these slides because it's all very anatomy based. I will cover some of that, but a lot of that stuff is covered in the lab videos. Now the heart has two circuits. One's called the pulmonary circuit, one's called the systemic circuit. When you hear the word systemic, always think body-wide. And so the pulmonary circuit, this is actually going to send blood to the lungs to pick up oxygen and then back to the heart with the oxygenated blood. And of course, it also transports the carbon dioxide to the lungs. So that's what the purpose of the pulmonary circuit is. It's a transport system to shuttle the oxygen back and forth from the heart and lungs. And the systemic circuit, this is what's actually going to send oxygen to the tissues. And that's going to, and the right side is the pulmonary, and the left side is the systemic, and we'll see that. The upper chambers of the heart are called atria. That's the plural. Each one individually is an atrium. The bottom chambers of the heart are called ventricles. And you can see that the right ventricle is going to pump into the pulmonary circuit, which we mentioned goes to the lungs to pick up oxygen, and the left is going to go systemically and supply the body tissues with oxygen. If you remember from the last chapter on blood, oxygen-rich blood is going to be more bright red, and oxygen-deficient blood or poor blood is going to be a darker red or bluish color. Now, when we're talking about different organ systems in the body, they're going to have coverings. And the heart has what's called pericardium. Peri means around. Pericardium is the double-walled sac around the heart. So there's two layers, and then one layer actually folds over to make two sublayers. So you have the superficial fibrous pericardium that's going to protect, anchor, and prevent overfilling of the heart. That's a thick layer, thick fibrous layer of pericardium. The second layer is called serous pericardium, and this one is made up of two parts. It's really one layer that folds over. So the parietal layer is the layer that lines the surface of the fibrous pericardium. Then it folds over, and what lays directly on the heart itself is called the visceral layer, and it's also called the epicardium, the visceral layer. Epi means upon, so epicardium upon the heart. In between these two layers, it creates a cavity called a pericardial cavity, which has fluid in there, and that's called pericardial fluid. Now, the purpose of that fluid is to decrease friction. We can visualize these structures, right, or these coverings, going from the outside in, going deep into the heart. We start out with that fibrous pericardium. We go through the parietal layer of the serous pericardium, and then the epicardium, which is that visceral layer, into the muscle layer called myocardium, and then the layer that lines the walls of the heart or the inside of the heart called endocardium. Remember, endo means within, and myo means muscle. When we see itis, we always think inflammation. So pericarditis is actually inflammation of this pericardium we just talked about. You get what's called a pericardial friction rub, which is a creaking sound that you can hear with a stethoscope. One of the things that oftentimes shows up with pericarditis is something called cardiac tamponade, and that's where fluid builds up and compresses the heart and makes it more difficult to pump, so it limits the pumping ability of the heart. Here are the three layers we talked about. Epi means upon the heart, right? It's the visceral layer that sits right upon the heart. Then you have the myocardium, which is the cardiac muscle, which makes up about 95% of the heart. So most of the heart is really just a muscle pump with a few associated structures and valves and things. Endocardium, endo means within, that's that layer that lines the inside. If we're looking at a picture of the internal structures of the heart with some of the associated blood vessels on the outside here, you can see the interventricular septum between the two ventricles, so between those two chambers. You can see the valves here. These are all things that we'll talk about, and cover in lab, but we'll be referencing some of these things like the valves throughout this lecture. Also, one thing I really want to point out here is we said that oxygenated blood is red and your deoxygenated blood is bluish. That's really important because usually when we look at something red, we go, oh, that's an artery, blue, that's a vein. And in the systemic circuit, yes, that is correct. But when we're in the pulmonary circuit, it's reversed. So let's look at this structure that I put a little X on here. And that structure is called the pulmonary trunk. You see it's blue. It's actually an artery, right? You would think vein because of blue, because veins usually carry deoxygenated deoxygenated blood. So something really important. Arteries always go away from heart chambers, and veins always go towards heart chambers. So for now, just think arteries away, veins towards. So arteries are going away from the heart, so they're pumping oxygenated blood to the tissues. Veins are draining deoxygenated blood from the tissues. However, that's the systemic circuit. When we're in the pulmonary circuit, we're taking blood to the lungs. What's the purpose? Well, it's to actually fill the blood up with oxygen, which means what are we doing? We're taking deoxygenated blood and sending it to the lungs. So the pulmonary trunk is an artery that branches into the left and right pulmonary arteries, which go to the lungs to pick up oxygen, and then we come back from the lungs. Remember, veins towards. We come back from the lungs and in the pulmonary veins to get back into the heart. And we'll talk a little bit more about that in the coming slides. So when we look at the external heart, a number of things we could look at here. One of the things I want to point out is you can see the superior and inferior vena cava here, and that those are the two primary vessels that drain deoxygenated blood from the tissues and bring it back to the heart. When we look at the back of the heart, we'll see another structure that drains into that right atrium as well. What I want you to see, though, and again, I put a little X on them, you can see on top of the atrium you have structures called auricles. And so when we're looking at this, the auricles are the structures, the atria are actually the chambers. So don't get confused with the labeling that they have on here. The auricle is that structure on the atrium. It's part of the atrium. Inside the atria, we have a muscle called pectinate muscle. Pectinate is only in the atria. Ventricles have different muscle that we'll talk about. You could also see, it talks about here the auricles, increasing atrial volume. Those are the structures I just mentioned on the last slide. Now, veins go towards heart chambers, right? So they're bringing deoxygenated blood, unless we're in the pulmonary circuit. Then we're coming back from the lungs with oxygenated blood in the pulmonary veins. But when we're talking about the systemic circuit and we're dumping into the right atrium, we're taking deoxygenated blood from the body from above the heart. The superior vena cava drains it into the right atrium. From below the heart, the inferior vena cava. And when we look at the back of the heart, and I'll show on a different picture, all of the blood vessels that supply the heart and get drained, and go into the tissues of the heart. Then we take the oxygen out and put it in the tissues and drain it into these veins on the heart, these cardiac veins, which are going to drain into what's called the coronary sinus, which is also a venous structure. And that coronary sinus will also dump into the right atrium. Again, once you learn the anatomy on all of these things, this will make more sense. Inside the ventricles, we have muscle called trabeculate carneae. This is the muscle that lines the walls of the ventricles. And you also have muscles in the ventricles called papillary muscles. These are the ones that connect to the atrioventricular valves. And they're connected by this cord tendon-like structure called chordae tendineae. And so there's two types of muscles in there. The papillary muscles look like these little thumb-like structures. And the trabeculate carneae, again, lines the ventricles. Kind of looks like Freddy Krueger skin. It's got that rough appearance. So, like we said, the right side of the heart is the pulmonary circuit. We're going to drain all the deoxygenated blood into that right atrium, getting it into the right ventricle, and then pumping it into that pulmonary trunk through the pulmonary arteries to the lungs to pick up oxygen. The left side being the systemic circuit, this is going to gather the oxygenated blood from the lungs into the left atrium, then left ventricle, pumping it into the aorta, which then branches and supplies the entire body. Now, if you think about this, how far is the heart from the lungs? It's really close. So when we pump to get the blood to the lungs, we don't need to pump with as much force. When we pump to try and push the blood towards the body, we're going to have to pump with more force. So the left ventricle or left ventricular wall, the myocardium, is going to be about 3 times thicker. In fact, when you dissect the heart, you can always tell which ventricle is which based on the thickness of the ventricle wall. In this cut here, you can actually see the thickness of the ventricle wall compared to the left side compared to the right side. Obviously, much thicker on the left. Now, when we talk about valves, you have atrioventricular valves. That's not their name. That is their category, right? So they are valves between the atria and the ventricles. There are 2. One of them is called the tricuspid valve. The other is called the bicuspid valve. The bicuspid is also called the mitral valve. An easy way to remember this is tri on the right. So RI tells you it's on the right side, which means the bicuspid's on the left, you also have to remember that another name for that, and actually a probably more commonly used clinical name, is the mitral valve. Now, what do valves do? Well, if we define the function of valves in general, we'd say prevent backflow. So wherever we have valves, they're going to prevent backflow of something. Well, we're talking about the heart here, and we're talking about a fluid in the circulatory system called blood. So what are these valves going to do? They're going to prevent backflow of blood. From where? Well, they're going to prevent backflow of blood from the ventricles into the atria. So we don't want the blood to go backwards. We want it to move forward, right? Papillary muscles that we mentioned before that connect to these AV valves by these chordae tendineae, they're going to contract, and when they contract, that's what closes the valve, and it prevents regurgitation. What's regurgitation? Well, it's the blood going back up into the atria, so it prevents that from happening. You can see here the picture of the valves and the chordae tendineae connected to the papillary muscles. When the papillary muscles contract, it flaps up the valve and closes off the opening from the atria into the ventricles. This way, when the ventricles contract, they send blood through either the aorta or pulmonary trunk and not back up into the atria. The valves leaving the ventricles are called semilunar valves. Again, this is a category, not their name. They're semilunar because the flaps are shaped like little half moons. You have the aortic semilunar valve, which goes into the aorta from the left ventricle, and from the right ventricle goes through the blood has to go through the pulmonary semilunar valve to get into the pulmonary trunk. Again, the purpose of valves is to prevent backflow. Now, we don't have muscles to contract to flap these valves shut. The way these shut is when the ventricles pump the blood through these semilunar valves, the backflow of blood slams those valves shut. So there's no muscle to do the work for these valves. Now, when we talk about the atria, so the entrance points to the atria, the pressure is extremely low as the blood comes back to the atria because arteries pump. So the heart pumps and then arteries pump, and we're pumping the blood to the tissues, but we drain blood in veins back to the heart. So when we get back to the atria, the pressure is extremely low. This is why we have no valves there, because we need pressure to open a valve. So how do we prevent when the atria do their little contraction with a smaller, thinner muscle to get the blood to move through the AV valves? How do we prevent it from leaving the atria, right, going the opposite direction? Well, when the atria contract, it actually compresses and closes the openings or entrance points of the atria. So it doesn't need valves, and because it's a very low pressure system. Here you can see I put a T on the tricuspid valve and a B on the bicuspid or mitral valve. I also put arrows going into the aortic semilunar valve from the left ventricle, and then an arrow going from the right ventricle through the pulmonary semilunar valve, just so you can get some visualization on what we just discussed. So some problems with valves: you can have an incompetent valve, so the valve's not working, or so what do we say valves do? They prevent backflow. So if the valve is incompetent, there's a backflow of blood. So depending on which valve is incompetent will depend on where the blood is backflowing into. Valvular stenosis, the flaps of the valve stiffen and constrict the openings, so now the heart has to work harder to push the blood through those valves. So these are two conditions that severely weaken the heart. Valves can be replaced. They can be replaced with mechanical, animal, or even cadaver valves. This slide takes you through the pathway of blood through the heart. What's really important to understand is that it's moving unilaterally. In other words, it's taking you through the heart as if you were riding on a red blood cell. You have to understand that the heart works, as we'll see later in the notes, as a functional syncytium. So both atria contract together, both ventricles then contract together, and so the blood on the pulmonary circuit is moving at the same time as the systemic circuit. When we're looking at this slide, it's just kind of taking you, again, unilaterally through, just so you can kind of get the pathway. I like this for a number of reasons. One, it helps you identify the structures, and then two, the pathway of where this blood is actually going, when we're on each side. But as long as you keep in mind that when the left side is pumping, the right side is pumping as well. I'm going to take you through the blood flow in the heart, but I'm going to do it on the actual picture. Okay, so when we look at this picture, we're going to start again as if we're riding on a red blood cell, and we're going to go through either the superior or inferior vena cava back from the body with deoxygenated blood we're going to get into that right atrium, that upper chamber on the right, and then it's going to move. So then both atria contract. We're going to move the blood from this right atrium through that tricuspid valve into that right ventricle. Okay. Then both ventricles contract. We're going to move the blood from that right ventricle through the pulmonary valve, the pulmonary semilunar valve, into the pulmonary trunk. It's going to branch, move to both, through the left and right pulmonary arteries, taking it to the lungs. We fill up the blood with oxygen, right? The red blood cells with oxygen. We take that oxygenated blood and we deliver it back to the heart through pulmonary veins. And I put little arrows there. You can see the red ones. And even though the ones on your left look like they're on the right side of the heart, they go behind and they empty, all the pulmonary veins empty into the left atrium. Then we're going to pump again, both atria, and we're going to move the blood from the left atrium through the mitral valve or bicuspid valve on that left there into the left ventricle. Both ventricles contract. We push the blood through the aortic semilunar valve into the aorta, into the aortic branches, and then to the body systemically, pumping the oxygenated blood to the tissues, and then rinse and repeat. Now again, the left and the right are actually happening at the same time. I just want to take you linearly through the structures. Another thing I want to make sure we're focusing on is when you're looking at the heart, and that's why on the last slide I said your left. When we're looking at the heart and we're looking at the anterior, we have to switch it, right? So on this picture, my left is their right and my right is their left. And you can see I wrote left and right on which side of the heart it is. But we have to get used to doing that. When we're looking at the anterior structure, regardless of which organ or whatever it is, we are looking, again, we have to make sure we flip it, right? Our left is their right, our right is their left. If we're looking from the posterior, then we're consistent where our left is their left and our right is their right. So if we're looking at the back of the heart, the posterior aspect of the heart, then the structures on our left are the left structures of the heart, if that makes sense. Okay, now we said there is a pulmonary circulation, there is a systemic circulation. So what is this coronary circulation? Well, the heart muscle also needs blood supply. This is not a separate circulation. The coronary circulation is actually a branch of the systemic, because we said the systemic feeds body tissues. So the heart tissue needs blood as well, and is fed by the coronary circulation. Now, essentially what's going to happen is blood supply to the heart muscle is delivered when the heart is relaxed, and the left ventricle receives most of the blood supply. Because again, what did we say about the left ventricle? It's going to have thicker muscle. Now, there's a term called anastomoses. Anastomoses means merging of vessels. And what you're going to see, arteries usually diverge, right? So they branch. They don't usually join. But in the heart and in the brain, you're going to see anastomoses. You're going to see merging of these vessels. Here you get a good visualization of the coronary arteries left and right and their branches supplying the heart muscle with oxygenated blood. This one shows the cardiac veins that drain the heart muscle, and all of the cardiac veins drain into that coronary sinus that's on the back of the heart. If you see how it's shaded on this picture, it's showing the back of the heart. I'll show a picture of that. And that coronary sinus, we said, is going to dump where? It's going to dump into the right atrium so that we can get it back to the lungs to get some oxygen. Here you can see I put a little X on the coronary sinus. We're looking at the posterior aspect of the heart. Now remember, my left is now their left, my right is now their right, and you can see the vascular system pretty well on this picture. Some homeostatic imbalances. You have angina pectoris. This is thoracic pain caused by a deficiency in blood supply to the myocardium. This is not a complete loss of blood supply. In this case, the cells are weakened, but they're not permanently damaged, so angina is not permanent damage to the myocardium. A myocardial infarction, which is a heart attack, this is a blockage, a complete blockage of blood flow to the myocardium, and this is actually going to cause death of cells. And this is a permanent permanent damage. What's going to happen is you will replace the cells with scar tissue, but the scar tissue is non-contractile, so it's non-functional. If we go back and we review our anatomy 1, we went over tissues and cells and things like that. And so when we look at cardiac muscle, let's review. Cardiac muscle is striated, just like skeletal muscle. However, it is involuntary. It also is separated by these structures called intercalated discs. And something I mentioned earlier is the cardiac muscle works as a functional syncytium. What does that mean? Well, it works as a single coordinated unit. So we have the atria contracting and then the ventricles contracting, and we've got a rhythm where the pulmonary circuit and systemic circuit are working at the same time. Also, the atria and ventricles are working in succession and not kind of fighting each other. In Anatomy 1, we talk about how cardiac muscle and skeletal muscles contract very, very similarly, but there are some key differences. And these three I want you to know, that cardiac muscle cells have what's called automaticity, sometimes called autorhythmicity. It's about 1% of the cardiac cells. And what it means is they can actually generate their own depolarization. If you remember from Anatomy 1, what happens is you need a nerve, an axon, right, to create a neuromuscular junction with a motor end plate of the skeletal muscle cell, and that event is going to generate an action potential. While the cardiac muscle doesn't need that, it can actually generate its own depolarization. A second thing, cardiomyocytes, the cardiac cells, they contract as a unit. So they either all contract or none. So it's all or none. Now we say that about muscle, but we only say it about muscle cells, or we say it about motor units, which is basically a nerve and all the muscle fibers or cells attached to that nerve. So when we fire it, it fires all or none. But let's say we contract the biceps. Well, not all of the motor units are firing, so it's not an all or none as far as the entire muscle. When we talk about cardiomyocytes, it's the whole heart contracts or it doesn't contract. So that's a difference there. There's also a long absolute refractory period. 250 milliseconds doesn't seem long, but what this does is it prevents tetanic contractions. What is that? Well, tetany is a sustained contraction of the muscle. We don't want this of the heart, right? Because it needs to relax so that it can contract again to pump blood, right? If we had a tetanic contraction, that's not going to be effective for the relaxation, which is necessary to recontract and keep pumping the blood. So now we're going to talk about the sequence of excitation, essentially the nerve impulse as it moves through the heart. And it's going to start at the sinoatrial node. The impulse moves across the heart at about 220 milliseconds, so this is a very fast event. Let's start off with the SA node. The SA node, known as the sinoatrial node, is also known as the pacemaker of the heart. It's in the right atrial wall. And what's going to happen is it's going to generate the impulse, okay? It's going to actually spread the impulse to both atria. I'll show a picture in just a little bit here. But it's going to spread the impulse to both atria. Why? Because we want both atria depolarizing at the same time, so they both contract at the same time. Remember, the heart's a functional syncytium. It's going to work as a coordinated unit. The AV node, known as the atrioventricular node, this is the delay center. So what's going to happen here is it's going to slow the impulse down. Well, why would we want to do that? Well, I would ask you, what moves faster, a nerve impulse or a muscle contraction? And I'm going to tell you the answer is nerve impulse. So if the nerve impulse is moving so fast, it moves into the ventricles before the atria have completed contraction, then we've got a problem. Because the ventricles can start contracting before the atria are done. And the ventricles are much thicker and stronger, so blood's going to wind up shooting up into the atria. So what this does, the AV node, is it delays the impulse about 0.1 seconds, and that allows the atria to finish contracting before the ventricles start their contraction. Once we move through the AV node, you move into the atrioventricular bundle, also known as the bundle of His, and that's going to carry the impulse. We move that wave of depolarization or impulse through the left and right bundle branches. And lastly, the impulse moves into the subendocardial conducting network, also known as Purkinje fibers. So this slide's really good because it sums up the entire process starting at the SA node. You can see the arrows going to the left and right atria, and that's where our depolarization is going to happen initially to cause contraction of the atria. We'll move through that AV node, slowing down the impulse, giving the atria time to finish contracting. Then again, moving through the rest of our branches to get the impulse throughout the rest of the myocardium of the ventricles, causing ventricular contraction. Looking at some more homeostatic imbalances, we have arrhythmias. These are irregular heart rhythms. So essentially uncoordinated atrial and ventricular contractions. Remember what I said before? They work as a single coordinated unit. So if they become uncoordinated, this is called an arrhythmia. Fibrillation, this is rapid irregular contractions, and this is not effective for pumping blood. So the circulation at this point ceases. And if we're not able to get the circulation started again, oxygen deficit to the brain causes brain death. The treatment for fibrillation would be a defibrillator. So you would use a defibrillator to try and reset the rhythm and contractions. Now, if you have a defective sinoatrial node, it could cause what we call an ectopic focus. An ectopic focus is an abnormal pacemaker. Remember, SA node is supposed to set the pace. If the AV node takes over, it sets what's called a junctional rhythm, which is a low heart rate. Now, low heart rate for an athlete is great, but low heart rate caused by a defective SA node or caused by an abnormal pacemaker, is not healthy. So 40 to 60 beats per minute. Again, sometimes you'll see athletes in this range. However, that's not what this is. This is essentially, it's not generating the impulse fast enough, and so your heart rate is too slow, so you're not really getting proper circulation. Extrasystole is a premature contraction, so it's an ectopic focus that sets a higher rate. Too much caffeine or nicotine can be the cause of this. Now, you have to get the impulse through the AV node, right, to get into the ventricles. So if you have a defective AV node, you can actually have a heart block. It could be partial, it could be total. If it's partial, only part of the impulse gets through. If it's total, obviously none of the impulse get through. But either way, the ventricles are not going to beat. They're either not going to beat or they're not going to be fast enough to sustain life. An artificial pacemaker would be the treatment for a heart block. Now, how do we measure the electricity in the heart? Well, an electrocardiogram, an EKG in German, which is where it originated, the term, or ECG, is an electrocardiogram. This is going to measure electrical activity, and it's going to have three different waves. You're going to have a P wave, a QRS complex, and a T wave. Let me talk about these on the next slide. If we look at our picture here, we have our P wave representing atrial depolarization. Now, if you remember from anatomy 1, we talk about muscles and contraction, and we have to depolarize the muscle to get the contraction, and then we have to repolarize, resetting, right? So it's basically, as we depolarize, sodium floods into the cell. As we repolarize, potassium floods out of the cell. Then we use the sodium-potassium pump and all that good stuff, right? Well, here's what I want you to know. If we depolarize, we have to repolarize, right? So atrial depolarization is necessary so we can get atrial contraction. That's represented by the P wave. That spike, that QRS complex, that's ventricular depolarization. And then a T wave represents ventricular repolarization. So where is the atrial repolarization? It's actually hidden under the QRS wave. So the atria do repolarize, but they're repolarizing at the same time that the ventricles are depolarizing. And this slide just gives you a visual, you can go look at it in your slides, of the depolarization and repolarization as we're moving through the heart. Now, if we're looking at ECG, a normal sinus rhythm, is your PQRST wave. And if you look at B there, the junctional rhythm, that's where we said the AV node takes over and sets the pace, okay? You can see the difference there. The P waves are absent in this picture. If you look at C, the second degree heart block, what do we say? Well, that means we're not getting the impulse, through into the ventricles properly, and so you don't see that QRS spike, right? You're not seeing it. You're seeing just a tiny little QRS wave. If you look at the ventricular fibrillation, it's kind of all over the place, right? So this chaotic rhythm of the ECG, this can happen in an acute heart attack. If you have electrical shock, it could cause this, and you would use a defibrillator to try and reset that rhythm. Now, heart sounds. The two heart sounds are lub-dup, lub being the first, dup being the second. The first heart sound, Now, this is not, you have to understand something. When you contract muscles, they don't make sound. So the contraction is not the contraction of the sound is not the contraction of the atria or ventricles. The sound is the closing of valves. So the first sound, that lub sound, is the closing of the AV valves. The second sound, the dup sound, is the closing of the semilunar valves. Okay. Now, a heart murmur is usually indicative of some type of valve problem, so either an incompetent or a stenotic valve. So if you hear a heart murmur, you would usually suspect something wrong with the valve. Your cardiac cycle is your blood flow through the heart during one complete heartbeat. So what I want you to understand is a little bit of terminology here. Systole means contraction, diastole means relaxation. So as soon as you see those words, you should translate them, systole being contraction, diastole being relaxation. Okay? So what we have is in this cardiac cycle is atrial contraction and relaxation followed by ventricular contraction and relaxation. The total volume of blood pumped by each ventricle in a minute is called your cardiac output. Now the cardiac output is your heart rate times your stroke volume. So let's break that down. The heart rate is how many times your heart beats per minute. And your stroke volume is how much blood is pumped out per beat. So that, again, if we add those up, right, then you get your total volume pumped out in a minute. If we look at an example, let's say your heart beats 75 times per minute, the stroke volume is 70 milliliters, you end up with 5.25 liters per minute. I'm not going to have you do calculations on an exam, but it just gives you a good example of how we're getting that total output. Now, if you increase either component, you're going to increase cardiac output, right? So if you increase stroke volume, the amount you're pumping out, you increase cardiac output. If you increase heart rate, you're going to increase cardiac output, or if you increase both, of course. The maximal cardiac output is usually 4 to 5 times the resting cardiac output. That's for a non-athlete. If we're talking about trained athletes, it can go up 6 to 7 times. So we're looking at that 5.25 average going up to about 35 liters per minute. Now, cardiac reserve, what is this? It's the difference between your resting and your maximal cardiac output. So if you take whatever you're at rest, and then as far as you can go above that, right, your maximal output above that normal cardiac output, that's what we call our cardiac reserve. So we said the stroke volume is how much blood is pumped out of a ventricle per beat. Well, let's break this down into an equation. The end diastolic volume, remember we said diastole is relaxation and systole is contraction, right? So we have to use our definitions. Our end of relaxation, right? Now this is talking about the ventricles. The end of relaxation minus the end of contraction. So what happens at the end of relaxation of the ventricles? They're filled, right? They're filling during the diastole. They're filling during the relaxation. So that's how much so take that volume, right, at the end of filling, and then minus how much they pump out, right? Minus the end systolic volume. So contract, push the blood out, or as much blood out as you can get out, and then whatever volume's left, that's the end systolic volume, okay? So what we're going to do is we're going to take our initial volume minus our end volume, and that's going to be how much actually left the chamber. Now, there are 3 main factors affecting stroke volume. We're going to cover each of these: preload, contractility, and afterload. So we'll look at these on the subsequent slides. The first factor affecting stroke volume is called preload. This is the stretch of the heart chamber prior to contraction. Now, there's something called Frank-Starling law of the heart. It says the more the heart fills with blood during the relaxation phase, diastole, the greater the force of contraction. So think of it like this. The more I pull back a rubber band, the more force it snaps forward with, right? So the more I fill the heart, the more I stretch the heart. And the more I stretch the heart chamber, the more it recoils and responds with a stronger contraction. Now, Frank-Starling law of the heart also says something else that I don't have on this slide. It says that preload is the most significant factor of the 3 that we mentioned that affect stroke volume. So preload is the most significant the most significant factor affecting stroke volume. Now, a couple of examples of preload. If we slow the heartbeat, we're going to have an increase in preload. Why? Well, a slower heartbeat allows for more time for filling of the heart chambers, and more filling means more stretch means stronger contraction. What about exercise? Well, exercise increases venous return to the heart. So the more blood returning to the heart, the more filling, the more filling, the more stretch, and the more stretch, the more force of contraction. Now, the reverse is also true. If you have a rapid heartbeat, that's going to allow less time for filling, and so that is going to decrease the actual amount of blood leaving the heart chamber per beat, so you're going to have a decrease in stroke volume. Blood loss, same thing, less blood getting back to the heart because there's loss of blood, so you're going to have less stretch. Less stretch means less preload means less stroke volume. Now, when we're talking about contractility, our second factor that influences stroke volume, it's anything that increases the contraction of the heart muscle, not including stretch. We said stretch has to do with preload, so if it's anything else that increases the contractility of the heart or force of contraction of the heart, then we classify it under contractility. If it's a factor, anything that increases contractility, we call it a positive inotropic factor. If it decreases contractility, we'll see on the next slide, it's a negative inotropic factor. Some things that are positive inotropic factors would be a sympathetic stimuli. So we talk about a fight or flight response. And actually, if you look on the second bullet point, norepinephrine and epinephrine are sympathetic hormones, right? So they're going to cause increased force of contraction of the heart. Think about exercise. Exercise stimulates the sympathetic nervous system, right? It's going to cause release of norepinephrine and epinephrine, and that is going to increase the force of contraction of the heart, forcing more blood out of the chamber, which means increased stroke volume. Thyroxine and glucagon are other hormones that can do that, as well as calcium and a number of other drugs. Some negative inotropic factors, or agents that decrease contractility of the heart. Acidosis would be an example. If someone, let's say, has a diabetic crisis and they have ketoacidosis, it could be any acidosis, but acidosis will decrease the contractility of the heart. Anoxia, which is extreme decrease in oxygen to the body, so hypoxia could cause that. Increased extracellular potassium could do that. Remember, potassium and sodium balances are super important for muscle contraction and nerve conduction, not just of skeletal muscles, but also of heart muscle. And then we said calcium is a positive inotropic factor, so calcium channel blockers would be a negative inotropic factor. Our last factor affecting stroke volume is something called afterload. What is afterload? Afterload is the pressure that you have to overcome to get the blood out of the ventricle into the tube, right? So into the arteries. So what is this? This is the opposite of the other two. The other two, if we had an increase in contractility, we had an increase in stroke volume. If we had a decrease, we had a decrease in stroke volume, right? If we increase preload, we increase stroke volume. This is opposite, because this is the pressure or friction we have to overcome to get the blood out. So the more afterload you have, the more you have to overcome to get the blood out, which means less blood gets out. So as afterload increases, stroke volume actually decreases. As afterload decreases, stroke volume increases. Hypertension, which is high blood pressure, atherosclerosis, the fatty plaques in the walls of the artery, these are things that would be examples of things that could increase afterload. And again, if we increase afterload, we reduce stroke volume, whereas preload and contractility, when we increase them, we increase stroke volume. Chronos means time. So when you see chronotropic, you're thinking it has something to do with time. So a positive chronotropic factor is something that's going to increase your heart rate. A negative chronotropic factor is something that's going to decrease your heart rate. We learn about the sympathetic and parasympathetic nervous system in Anatomy 1, but to review here in regulation of heart rate, the sympathetic nervous system, we know that excitement, exercise, right, all the E's, stress and anxiety, these things also will, we talk about that, it'll increase the heart rate, right, along with a number of other effects. We're just talking specifically about heart rate here. So a sympathetic nervous system response is going to be a positive chronotropic factor, right, because it's going to increase heart rate, whereas parasympathetic is a negative chronotropic factor because it's going to decrease heart rate. So at rest, the heart's going to exhibit something called vagal tone. This has to do with cranial nerve 10, the vagus nerve. It inhibits the heartbeat, slowing the heart rate. Now when we say inhibit, it doesn't stop it, it just slows it. And that vagus nerve is controlled by the parasympathetic nervous system. Now there's a reflex called the atrial reflex. It's also known as the Bainbridge reflex. And this is essentially a protective mechanism. So this doesn't happen every time the heart beats, but if there is an increased atrial filling to the point where it's too much, what's going to happen is there's going to be a stimulus that causes the SA node, which remember that's the pacemaker, to increase the pace. So it's going to increase the heart rate. Well, why would we increase the heart rate? Well, if it's filling too much, we're going to increase the heart rate because, as we said before, by increasing the heart rate, we have less time for filling, and less time for filling means less stretch. When we're looking at some hormones that regulate heart rate, epinephrine is going to not only increase heart rate, but it's also going to increase contractility. We mentioned that when we talked about contractility, the sympathetic nervous system response. Epinephrine is adrenaline, and so that's going to increase heart rate as well. So it actually increases the contractility and the heart rate. Thyroxine, which is thyroid hormone, increases the heart rate. It also enhances the effect of both norepinephrine and epinephrine. Some imbalances that we're just going to memorize. Hypo means decrease, hyper means increase, right? So if we have hypocalcemia, this is low calcium in the blood, that's going to depress the heart. If we have hypercalcemia, that means too much calcium in the blood, that's going to increase the heart rate, and it's going to increase contractility. Kalemia, what is this? Well, kalium is the Latin name for potassium. That's why it's K on the elemental chart. So hyperkalemia is too much potassium in the blood. That's going to mess with the nerve conduction and electrical activity in the heart and muscle contraction as well. Because remember, sodium and potassium are necessary in proper balances to have proper nerve conduction and muscle contraction. So hyperkalemia can lead to heart block and cardiac arrest. Too little potassium in the blood, hypokalemia, can cause a feeble heartbeat and can also lead to arrhythmias. When we look at some other factors that can impact heart rate, we have gender. Females generally have a faster heart rate than males. Youth, so fetus has the fastest heart rate. Infants are also going to have faster heart rates than adolescents and adults. Exercise. Exercise will increase your heart rate while you're exercising, but if you exercise consistently, it will actually lower your resting heart rate. And body temperature is another thing that can affect heart rate. As the body temperature increases, the heart rate also increases. When we look at classifying imbalances for heart rate, tachy means fast, brady means slow. So tachycardia is an abnormally fast heart rate that's above 100 beats per minute. This is super important. This is not when you're exercising, right? That's normal to go above 100 beats per minute when you exercise. This is at rest. So if you're over 100 beats per minute at rest, it's classified as tachycardia. If you're at or below 60 beats per minute at rest, it's considered bradycardia. Now, this is not necessarily bad. If you remember earlier in this chapter, I mentioned that athletes will generally have lower heart rates, so that is actually can be very healthy. So if it's not an athlete and it's caused by something like an ectopic focus, well, then the bradycardia can be something that's problematic. All right, last but not least, we have congestive heart failure. This is a progressive condition. There are 4 key things that contribute to congestive heart failure. So first, what is it? Well, it's essentially you can no longer meet the needs of the tissues as far as pumping oxygen or pumping blood to the tissues to get them the oxygen that they need. Okay, a number of things affect this. Atherosclerosis, which is the plaquing, the fatty plaques that form in the walls of the arteries. That's one thing that contributes to it. Persistent hypertension or high blood pressure is another. Multiple myocardial infarctions. Remember we said that a patch of the heart dies during a myocardial infarction. So if we have multiple, then there's more mass of the heart that's lost its contractility because it heals with non-contractile scar tissue. DCM, dilated cardiomyopathy. This is when the ventricles stretch and they lose their contractility. So the myocardium actually deteriorates. So think of it like your waistband losing its elastic. So the chambers are losing their elasticity. And these all affect each other because atherosclerosis can have these plaques that could break off and cause a myocardial infarction. The high blood pressure might break off the plaque. So these are kind of all intertwined, but these are the 4 key things that contribute to congestive heart failure. That wraps up the heart chapter. We'll continue with the next chapter with blood vessels.